here, but we'll probably have a few more that come in at the tail end. But anyway, I'd like to first talk about what's going to happen in October, so we don't forget to do that. October, we're going to have a presentation by David Stanley. I don't know if you know David, but he is in charge of the Kaleidoscope Center and with the Milkweed Association, which supports, it's a peer support group for drug dependence and emotional support for that. It's a beautiful place that they have in the basement of the city center, which is on 9th Street in Wilson. So he'll be here to, that's one thing that we would like to do, is let people know what's available in Menominee. Like in November, we're going to be telling everybody about the emergency response organization through the county. And if you know other groups that would like to speak to us, to let us know what they do for us locally or in western Wisconsin, let me know that they would like to be our speakers. So today we are so privileged to have Dr. Paul Horvath speak to us, and he's in charge of our local Mayo here in Menominee. He is a very well-educated person. He went to the University of Wisconsin for his medical school training, and then he went over to Kalamazoo to get his training in emergency medicine. And I personally have met him in the emergency room. He's a fantastic physician. And I am so delighted that he is willing to speak to us today about issues that would concern us about the future of healthcare. So with that, I'll turn it over to Paul.
Good morning, everybody. Before I get started, I'll just do an audio check. Is volume okay if I stand here? Come forward. How's that? Is that better? Okay, good. I get a thumbs up from the back. Perfect. Yes?
People should raise their hands if they can't hear you.
Please do so. Can yes. Everybody can hear me okay? I'm just kind of looking around at faces. Okay, perfect. Brilliant. So thanks to Dr. Vetter, I appreciate it. I can't say that I'm in charge of anything, just for correction. I remind everybody, I remind my board on a regular basis that no one actually reports to me. My clinical background is in emergency medicine. I'm a community doc at heart. I went to a community residency training program. I really enjoy taking care of ill and injured people, patients, and solving some complicated problems. I've spent time working at various levels of healthcare through my career, from small combat outposts on the battlefields of Iraq and Afghanistan. I've worked at all 5 of the Mayo hospitals here in this region and other regions as well. I've worked at critical access hospitals in 3 states across the Midwest. I've more recently gotten into healthcare leadership. I've spent 7 years as a department chair for the Department of Emergency Medicine here at Mayo Clinic in Northwest Wisconsin. I've served as a department chair for the urgent care practice, also at Mayo. And fortunately, just over the last 4 years, I've really gotten into hospital level leadership, which has really expanded my brain, thinking outside of the emergency department and trying to really understand a lot of these issues that are outside of my clinical scope. This timing is really amazing. I was talking to Dr. Vetter earlier this morning. In the last 2 weeks, I've been at 3 conferences, 3 individual conferences, each of them speaking in their own way about the future of healthcare in the area of particularly rural healthcare. So I couldn't have planned this timing any better. I'm hopeful to bring some of those messages to you. I want to just start with a few thank yous. Again, thanks for the invitation to speak today. I really am grateful for that. I've had a number of colleagues help me pull together some content and review and edit what I'll talk about today. And then I specifically want to call out Mr. Matthew Stanford and Mr. Eric Borgerding, both from the Wisconsin Hospital Association. I have blatantly stolen some of their slides with their permission, and you'll recognize which ones those are. Lastly, we should have plenty of time today. I put together about 45 minutes or so of content, and then there should be plenty of time for questions and conversation afterward. I may ask for some participation depending on how things go kind of during my presentation. Otherwise, what I'd prefer, if it's okay with you, is just to save questions and discussion for the end, if that's all right. Okay, brilliant, thank you. So my hopes today really are three things. I want to take a little bit of look in the rearview mirror and try to have a little discussion about where the U.S. healthcare system has come in the last 120 years or so. So we'll start in the early 1900s and work our way forward. That's going to give us a background to help us understand why we are in the position we're in now. And then looking forward, and this is purely speculation, but just some thoughts on where I think the healthcare system in general may be going. I'll add some thoughts particularly about my practice at Mayo Clinic Health System in Menominee. I would appreciate other thoughts from other organizations. I don't know if there's representation from any of the other healthcare organizations in town in the audience. But just know my comments are going to be both fairly high level and then fairly biased to what I do and know on a day-to-day basis. So looking back, the healthcare system in the US is incredibly dynamic. It has evolved tremendously in the last, again, 120 years since the early 1900s. This slide is entirely unreadable. It's not intended for you to read, but I just wanted to give you a flavor of some of the high points and some of the changes that have evolved in the healthcare system since 1900. This graphic I like a bit better. It really puts that evolution into periods or epochs that I think are well thought through. You know, as we talk through, we'll talk about the education, we'll talk about the payment mechanisms, we'll talk a bit about government involvement, and again, try to understand that history. I'll tell you though, my favorite way to look at the healthcare system is a little bit more lighthearted.
The practice of medicine is a demanding profession.
Who knows what this is? What is this? Perfect. Yeah. So this is Marcus Welby. Marcus Welby, for those who aren't familiar, was ran in the 60s and into the early 70s. How about this one? A little different style, huh?
Your favorite show in medical school.
Absolutely. In college, for that matter. Anybody remember this one? Oh, and this one's not going to load. This is one that I remember my parents watching when I was a kid. A lot of familiar faces in there. All right, I've got to do one last one. So you can see, even through television, how the healthcare system has evolved and how portrayals of the healthcare system have evolved. So if we go back to the pre-World War II area, of course there wasn't a lot of TV there, and I couldn't find any good TV clips to reference. Who knows who this artist is? Yeah, this is Norman Rockwell. So pre-World War II, even back into the late 1800s, medicine was really a cottage industry. Even going back into the 1800s, most care was actually done by the women of the community. Nursing had its precursors at that time. Medicine, as we know it today, physicians as we know it today, really didn't exist until the late 1800s, early 1900s. Our understanding of physiology and disease was incredibly limited. And the focus of healthcare really, frankly, was care, because there really wasn't a whole lot of cure there. The relationship between a patient and the caregiver was really paramount. That I think is really what's depicted here. in this Norman Rockwell painting. And of course, payment was often on a barter system. Payment was kind of an afterthought in many ways. As we get into the war era, by this time medical education has really formalized. Medical schools across the U.S. are abounding. There was some federal laws that were passed that actually started to fund medical schools. Medical schools themselves were pretty unregulated, and having a medical degree often equated to having a license to practice. And frankly, the quality of medical education was inconsistent at best. Most physicians in this time were independent small business owners. The group practices were really just starting to have their early foundations. And specialties were very much at their infancy. There were a few specialties, ENT, gynecology, dermatology, which I found fascinating, were kind of early developments. And organized medicine was really starting to form even back into the 1930s. The AMA and the American Board of Medical Specialties got their starts at that time. As we get later, I'm sorry, one other point here that I forgot to make. At this time, public health insurance, private health insurance, excuse me, was getting its first legs. There were two experiments, one at a hospital in Dallas, and one out on the East Coast with the Kaiser Group, were early forays into private health insurance. As we get into the post-war years, then industry and business used private health care as a draw to get workers back into industry and really boost up the economy after the war. Then as we transition into the Marcus Welby time, by this era, obviously there's a fair amount of tension here between the old and the young, and frankly that's what's reflected in the Marcus Welby TV show. After the war, again, a number of federal movements really started to regulate medical education. So actually the number of medical schools went down for a period of time, but the quality of education arguably went up, and there were some standards supported there. It was here that medical research started to get a boost from the U.S. federal government as well. And that really subsidized a lot of large university medical schools. In the mid-'60s then is where public health insurance finally got its start. There were conversations about Medicare and Medicaid and other mechanisms for public health insurance, again dating back decades before that, but it wasn't until 1965 that Medicare and Medicaid really got their start. And then interestingly, as we get into the 70s, we start to see already some very early forays into managed care. Some of the challenges at this point is, and part of the reason why Medicare got founded in particular was poverty, particularly among the elderly, was a tremendous problem. And as technology grows and as medical specialization evolves, people learn that the elderly in particular started to not be able to afford care. There's an interesting theme here that medical knowledge, technology, specialization, healthcare kind of evolved in parallel, and each feeds on the other. Who knows this one? This one I didn't have a clip of. Doogie, yeah, absolutely. As we get into the 80s and 90s, there are some demographic shifts here. Many more women started attending and graduating from medical schools. This is really when we get into the age of managed care and health maintenance organizations and risk-based, so-called risk-based contracting. The other thing that happened here is the internet. The internet really was tremendous at improving outreach and really added to everybody in the country's health literacy. People were able to get medical information with relative ease. By this time, medical specialization is really in full swing. The amount of medical knowledge that existed was frankly impossible for any one person or any one specialty to keep in his or her mind as medical research really flourished starting in the 70s. That drove the development of medical specialization. And that then also drove tremendous rises in healthcare costs, hence the development of the managed care organizations. By this point, physicians are aggregating. By this point, healthcare is no longer a cottage industry. It's no longer a self-employment kind of situation. Physician groups, mostly single specialty groups, are evolving, and those groups then have contracts or relationship with hospitals to provide their care. And I didn't mention on this, but hospitals are actually a relatively new innovation here as well. Hospitals grew out of the poorhouses and the almshouses of the 1800s. By the time we get into the early 1900s, there were some development of some public hospitals that then, of course, got a kick from the post-war era and some federal funding to develop into many of the hospitals we know today. Interestingly, in the 90s, sorry, I'm bouncing around here a bit. In the 90s, really is when we start to see the rise of so-called alternative medicines and interest in alternative medicine. All right, so let's move up then into the millennia. There's a fundamental shift in healthcare funding at this time. Thanks to the federal government and others, there's a transition here from fee-for-service based billing, which is pretty intuitive and I think is what a lot of people think about for healthcare billing and frankly other financial interactions, to value-based billing. And we'll see that trend continue up till today. And that comes from the early HMOs that frankly failed miserably back in the early 90s and late 1980s. Despite a tremendous rise in technology and relatively easy access to healthcare as we look in the U.S. compared to the rest of the world, we continue to see tremendous gaps in care. And that was really highlighted in the urban ER of that era. We see racial gaps, we see geographic gaps, we see financial gaps. And again, despite tremendous science, we start to recognize that there are major swaths of the population that just simply don't get the care or can't get the care that they need. So let's come up to today. Today, we are in a we're in a situation where healthcare truly is big business. Healthcare is tremendously regulated at the state and federal levels. The U.S. expenditure on healthcare is among the largest in the developed world. Again, unfortunately, our outcomes in healthcare are not among the highest in the developed world. By this point, the vast majority of physicians are employed by a hospital or health system, as I am. Independent practice is relatively uncommon and relatively rare. In the US, 57% of hospitals are not-for-profit. Roughly 20% are public or government hospitals, and 25% of them are individual for-profit hospitals. In 2022, 70% of the hospitals across the US operated at a net loss. And of course, the vast majority of that expense is guess what? It's people, it's human resources. And of course, all of that was exacerbated by COVID. I've heard COVID described as healthcare 9/11. COVID didn't cause any of those, or didn't cause many of those challenges. But of course, it exacerbated problems that have already been there, structural problems within the healthcare system, problems with the financial incentives to provide high outcome, excellent outcomes, and frankly, problems with staffing. So let's talk a bit about healthcare finance in today's world. You can see that the government, in one way or another, actually pays for about 50% of healthcare in the US. So we can talk as much as we want about the problems of Medicare and Medicaid funding, but we also have to recognize that the government is the 900-pound gorilla in the room. Only about a third of those costs, about a third of those dollars come from private insurance, and a relative minority is out of pocket. So let's talk a little bit more then about Medicare and Medicaid. We know that Medicare and Medicaid enrollments have been rising tremendously over time. You know, I did a little bit of math here. In 1966, so this is the year right after the bill was signed to start Medicaid, the US population was under 200 million people, and there were 19 million people that were enrolled in Medicare. So that was about a 10-to-1 ratio. As we come up today, that ratio has dropped to 5-to-1. So I think all of us who are, I'm not coming up on retirement age yet, but I know many of my colleagues are, and I was talking to a few of them beforehand, and they made the point that they thank every working person that they're paying for their health care insurance. Because those of us who are still working are funding a relatively larger percentage of that. Similar trends in Medicaid. When Medicaid kicked off in 1966, the ratio was about 18-to-1, and now it's down to 4-to-1. So population is growing, but we also know that the population is aging, and the Medicare and Medicaid enrollees are going up faster than population growth. We've all heard about the challenge of inflation over the last few years. We know that that's hit the healthcare sector as well, and we've been feeling that again since the challenges of the pandemic. This is one of those data points that I'll say borrowed from my colleagues at the Hospital Association. Interestingly, what we think of as the real costs of healthcare, the bedside care, the inflationary, the CPI has gone up relatively modestly in the range of 3%. I don't know if you can see with the heading under that big red bar there off to the right of the screen, but that's the inflation in healthcare insurance. So that's up almost 20%. So we are in a pretty tough business environment in today's world. We know that healthcare workforce is in a tough place for a number of reasons. Again, the regulation is kind of a mixed blessing in healthcare. In 1997, Congress actually enacted a cap on physician residency slots. So let me explain that. So physicians are trained almost in a apprenticeship type of model. So we go through undergrad college, or I went through undergrad college, 4 years of medical school, and then into my specialty training. Most of that funding for specialty training comes from Medicare and Medicaid. The vast majority comes from Medicare and Medicaid. In 1997, in a cost containment measure, the Congress put a cap on physician residency slots. So no additional residency spots have been allotted since 1997, despite a known predicted gap in the number of physicians that we need to provide care to the country. Some statistics from the American Association of Medical Colleges, the AAMC, estimates that by 2034, there'll be somewhere between 30,000 and 120,000 physicians, a gap in the ability to provide those care. So 30 to 120,000 physicians will be needed that won't be available. And that's the physician side. As we look at the technical side, or the ancillary care side, the registration clerks, the housekeepers, the lab techs, we've really run into challenges simply recruiting those people. We know that healthcare is a challenging environment. Any of you who, I'm looking at the physicians I know in the room, or those who have interacted with the system, we know healthcare is a tough environment. As a physician, we know the hours are long, the duties are seemingly never ending. I'll tell you, for a nurse, it's brutal. The care the work is physical. For our registration clerks, they're really at the cutting edge. We've seen challenges in the last few years of patients. We've seen workplace violence episodes go up dramatically in the last few years. And unfortunately, it's our registration clerks who are right at the front end of that, and often feel the brunt of that when people call in for appointments. So it's a tough environment. It's a tough environment to recruit to. And of course, the pay is challenging. We hear frequently that people can go work at Walmart for similar pay to being a registration clerk at the hospital. And why would they come work for us when they can have a job that they can work day hours and not have to take the abuse? Yet we need those people. We absolutely need those people. We talked a bit about the inflationary pressures already. I'm not going to harp on that too much more, other than to say, just a kind of sense of scale here. I was working with my team to put together a budget in the last couple of weeks. What we've seen is inflationary rate costs go up by about 10% predicted for the next year, and revenues go up by about 5%. So that math just doesn't work out. And of course, funding and reimbursement. We had a lot of benefits, financial benefits to keep particularly small hospitals open during the pandemic, and a lot of those programs have dried up recently. This is interesting. Long-term care, so nursing homes, are also feeling a lot of the same pinch. There's a bed cap for nursing home beds in the state of Wisconsin. Over time, the number of licensed beds has gradually drifted downward, which then puts particularly older folks really in tough positions trying to get admitted to nursing homes when they need that care. And it trickles back to my practice in the ER. When we can't get a nursing home, a patient who needs a nursing home bed out of the hospital, they stay in that bed, and then I can't admit the next person into the hospital. So we've seen boarding in the emergency department go up dramatically directly as a result of this challenge. We've all heard about the challenges with behavioral health care, psychiatry, and psychology. Behavioral health care, I think, is on every community health needs assessment as a high priority item in every community that I've heard of in the last number of years. And then we come to the public health infrastructure. And I was actually really hoping that KT Gallagher, our public health director, was going to be able to be here today to add some comments. But hospital and healthcare organizations have really felt some pressure to step into that space because the public health infrastructure, frankly, has been gutted. And then I'm going to try not to get into politics, but healthcare, the challenge of healthcare is agreed on only slightly less than the fact that the Republicans and the Democrats can't agree. So right now we're in this really tough position of trying to manage our business while taking care of the population, while working to increase our quality, while trying to grow our workforce, and while becoming a community safety net. Sorry, I'll go through a couple of Eric and Matthew's slides here. So last topic here in this kind of section. There have been some really interesting developments in healthcare since my residency training, and the development of the electronic health record, the electronic medical record is one of those. And again, I really think that was developed in from a good place. That came from a good place of hope and quality. Unfortunately, the unforeseen impacts of that have really been dramatic. And again, Megan, I'm looking at you here. You can probably tell stories here better than I can. But the impact on physician work has been tremendous. You can see pre-EHR, most physician time was spent at the bedside, doing face-to-face care, doing what we all love to do. And in a post-EHR world, that has been cut dramatically. So less than half of our time is actually at the bedside. And as we look at other developed countries, the discrepancy is real. So this compares the UK to the US, and you can see the amount of face-to-face time we have in the US is dramatically different than that in the UK. And again, I don't want to bag on the EMR. I think there's real benefits there, including some safety benefits, and I'll get into some of the big data stuff later. But there's real challenges that come along with that. So all of those pressures have landed many hospitals in hot water. This is data that comes from the National Rural Health Association. So I actually just got back from their annual conference yesterday. So since 2010, more than 150 small rural hospitals have closed in the US because of exactly these pressures that we've just discussed. And you can see that trend just in the last few years is rising. The direction is going the wrong way. And you can see where many of those hospitals are located. What's interesting here is the definition of small is gradually getting bigger. So as I look at the healthcare newspapers, Becker's Hospital Review is a common one. As I watch the healthcare news, we're starting to see healthcare organizations that we all thought were solid performers really struggle. We've seen the rise of healthcare. We've seen trends in healthcare leaders resigning or taking different jobs. We've seen healthcare organizations start to limit services that we thought would never ever happen. And again, it's not just the small 5-bed hospital that relies on 2 doctors and a nurse to manage. It's suburban hospitals that are in relatively affluent areas that are starting to feel those pressures. And oh, by the way, we're in that category. We have been relatively insulated to a lot of these pressures here in Menominee for decades, and we are certainly starting to feel those as well. Despite all of that negative stuff, there's lots of bright points here. And again, I want to thank Eric and Matthew. In Wisconsin, we have sorry, I'm trying to read my notes here, the 4th largest share of 5-star hospitals in the country. We're the 2nd best in the country for rural hospitals. We're in the top quartile in the nation for quality of care. We have among the lowest cost of care in the country, and we have the relatively few patients who are not getting care because of that cost. So Wisconsin is absolutely a bright spot in the country. And specifically, as we get into Menominee here in Dunn County, I'll tell you, I'm actually really excited about our future, and I'm incredibly proud of what we have here. We just went through a Joint Commission survey. So the Joint Commission is a contract agency that accredits hospitals in the country. We breezed through the Joint Commission survey. I got to spend every day with that surveyor and that survey group when they were on our campus. And I'll tell you, they really struggled to find risk. They really struggled to find things that we're not doing excellently. Shortly after the Joint Commission survey, the state showed up, and we had our trauma survey. And once again, we are accredited as a level 4 trauma center here in Menominee. Recently, we just got recognized by CMS, so the Center for Medicare and Medicaid Services, as a 5-star hospital. And much of that is thanks to my team's work to provide excellent patient experience. This one I'm super proud of. I just got back from Kansas City. We were recognized by the National Rural Health Association and the Chartis Center as being one of the top 20 critical access hospitals in the country. And hopefully I can come back here in a few weeks and tell you that we have been recognized by the Magnet organization. I don't know if there's any nurses in the room, but Magnet is an organization that really supports nursing culture. And if we get this, and we fully expect to, that this will be a real coup. There's been no system as ours is that has every hospital recognized by Magnet as a great place to work for nurses. Thanks to you, thanks to the Menominee and Dunn County community, our volumes are really strong. So this is a graph of outpatient visits just over the last year, and you can see every month we are exceeding what we thought would happen with outpatient visits. That shows incredible trust in the care we can provide. And this is our surgical practice. We've done some really innovative things with surgeries since the pandemic. Pre-pandemic, the number of surgeries that we did here in town was on a gradual downhill slide, and we've turned that around. You can see the number of surgeries that we do here in Menominee vastly outpaces what we did pre-pandemic. So again, there's lots of challenges here, don't get me wrong, but I'm really excited about our future as we go forward. So let's take that as a transition, and let's actually start to look into the future. Where do we go from here? So there's a few themes that I think are going to continue to play out. I think workforce will still continue to be a challenge. We know that we don't have enough physicians to meet the needs. We know that not only is the population aging, which adds to the complexity of need and care, but our physician workforce is also aging. And we're expecting many of those docs to retire in the coming years, and we just don't have the pipeline to replace them. So here's where we get an opinion, and I want to be totally transparent about that. I think we're on a precipice, on the verge of a transition. I think going forward into the future, physicians will need to lead interdisciplinary teams. I don't think I know there's not enough of us to be at the bedside to provide all the care that's needed. So I think what's going to happen is we will need a team of people around us to actually implement the care that we direct. So that's going to mean creating new jobs. That's going to mean creating new roles. That's going to mean working with our educational partners like the UW Scout and UW Eau Claire to educate those folks. It frankly will probably mean training some of those jobs ourselves, and we will need to develop our own training programs to build out that workforce of the future. We've seen consumerism, and I'll define that term here in just a minute. We've seen consumerism be a real challenge. We've seen folks like Amazon and Walmart dip their toes into healthcare. Organizations that, in my viewpoint, have no business providing healthcare. And the reason they're able to do it is because they can meet patients where they are and when they want the care and get them the care that they need. Now, granted, a lot of that is done through virtual tools, through video visits. But we've also seen that has been a real desire, particularly of some of our younger, more tech-savvy patient population. So I hope, going forward, healthcare is going to be shaped by that. I know it's going to be shaped by that. My hope going forward is that healthcare will be much more personalized and will really meet, again, people where they are. So, as we couple consumerism and workforce challenges, we'll need to develop some virtual tools to be able to do that. One of the conferences I was at early last week was really talking about the future of technology, primarily computer technology in healthcare. I'll tell you, artificial intelligence is going to grow and needs to grow. I think we've learned a lot during the pandemic about the care we can provide without physically sitting face to face with someone. And I absolutely expect that will grow as well. Again, this is out of my clinical wheelhouse, so I would turn to others in the room to chime in here if you want to. There's an organization called the U.S. Preventative Services Task Force, USPSTF. And what the USPSTF does is it really sets best practice in terms of screening and management of kind of chronic diseases. And that's all based on population data, right? So the question I always ask is, how do I take that population data and apply it to the person, the one person sitting in front of me? So I hope going forward we'll be able to use some of that information technology to help us personalize that care, to really target individuals' needs in a much better way. And the only way we do that is by taking the data that we've collected over the last decade from our EMRs and plug it through artificial intelligence engines to help us understand that. And I think that work is already coming. One of the CEOs was listening to a panel of CEOs from a group of small hospitals out in, I believe it was Washington State, yesterday afternoon. And one of the gentlemen made a pretty bold comment that he hopes in the future we get beyond talking about ACOs. So ACOs is an accountable care organization. Again, that's a Medicare funding. We talked a little bit about managed care and value-based care. So in the setting of an ACO, organizations are paid based on the outcome of their population. So it's not, you come in, you get a physical, you pay $20. It's, you come in, you get a physical, and if you don't have a good outcome, we as a healthcare organization lose money. But if you have a great outcome, we may make some money. So that's kind of the general concept of an ACO. And of course, that's all done on a population basis. This gentleman was saying, yeah, ACOs are absolutely important in helping us make that transition from volume to value, which is it's a fundamental shift in the way healthcare is funded, and I think a necessary shift. But what he's really hoping is that in the future, there'll be no debate whether an ACO is the right funding mechanism, because everybody will be doing it. So as far as the delivery system goes, I fully expect to see more mergers, potentially more closures of hospitals. I've told this story to my board a few times, but I truly believe that if we were not, we here at Red Cedar at Mayo were not part of a large healthcare system, there's a reasonable chance that we wouldn't exist. Small independent hospitals continue to close, and unless there's shifts in funding for those and staffing for those and volume of those hospitals so that staff can maintain some expertise, I think they've got a choice of either closing their doors or joining with a large system to take advantage of some of that scale. I've already hit on the payment models. Again, I think value-based care will continue to grow. I don't think there's any question in my mind in that. And I think information technology is necessary primarily in order to support some of the workforce challenges that we're all seeing. So again, what does that mean for us here at Mayo Clinic Health System Red Cedar? And I'll tell you, my leadership team and I are in the process of really clarifying that vision for us for the next 5 to 10 years. And that is not set in stone yet. I don't have a vision statement to share with you today, but hopefully we'll get nailed down in the coming weeks. But I think our forte here in Menominee is going to be primary care. I see growth in the primary care world. We know, I'm looking at Dr. Vetter in the back corner, we know that general internists just are not being made anymore. We know that most of the people graduating from internal medicine residency go off into medical specialties to become cardiologists or pulmonologists, and general internists are hard to find. So family medicine, I really think, is going to be the primary manager of adult care. In the I see. I'll get to a question here. That I think family medicine will be the primary manager of outpatient care going forward. And fortunately, we've had some really great recruiting there, and we'll continue to build on that. I do think we will continue to grow in some specialty service lines. We're seeing movement right now in oncology and infusion services, so oncology infusions and non-oncology infusions. And we've got plans to grow out that service here in Menominee, hopefully in the coming year. And we'll see other selected opportunities like that. I think healthcare organizations will need to do a real heartfelt analysis of what they can provide and go all in on that, and then look outside of their walls and partner with other community organizations to provide those services that just can't be provided within the walls of the hospital. So that's the outpatient side. If we look at the hospital side, again, I only see growth here. In the last couple of years, we have added what we at Mayo call a progressive care unit. So that's a 4-bed unit in our hospital that's able to provide a little bit higher level of care, a little more complex care than might happen on a regular general medical board kind of situation. And that is supported by a virtual technology called EICU, electronic intensive care. So those nurses and doctors, those staff, essentially they've got the easy button on the wall, literally. So when they need help or assistance or again another higher level thought process, they can very easily consult with colleagues in the intensive care unit in Rochester, either nursing or physician or both, frankly. I was doing a resuscitation in our PCU a few weeks ago. helping out one of our hospitalists, Dr. Gasai. And I can't tell you how wonderful it was to have an intensive care doctor and an intensive care nurse on the screen up at the foot of the bed, helping me manage that patient who was frankly in extremis and doing poorly. We are working to make lemonade from lemons. We know that we have not had gynecology. We know that like general internists, gynecologists are incredibly hard to find. We know that even major markets like Phoenix, Arizona, has far from enough gynecologists to manage the patient population that they need. So you all know that we've had to shut down our birth center here in Menominee. We're working to turn those into inpatient beds. So we'll have an additional 6 inpatient beds going forward. We will top out at 30 beds in that hospital. One of the requirements to maintain our critical access hospital is to have no more than 25 inpatient beds. And we'll have an additional 5 beds for outpatient observation kind of services. So we will absolutely max out the space that we have available to us. We'll also continue to work with our colleagues in the transitional and long-term care space. So we see people who have gotten their care in Eau Claire or Rochester. They've had some complex surgery, but they need more time for rehabilitation before they can go home. We continue to work with our colleagues in what we call transitional care to bring those folks closer to home, so they can rehab here near their families before they can get back home and get back to their day-to-day lives. And then of course my baby, our ER continues to be full and growing. We provide an incredibly high level of care for a community hospital. We have the 2nd busiest ER in our region, and the busiest critical access hospital ER in Mayo Clinic. So we will continue to grow that. As we look at the surgical and procedural practice, I showed you the data earlier that we've had a major shift in surgical care here. That really, I want to call out Dr. Wayne Wu in particular. Wayne is the chair of ophthalmology for our region. Thanks to him and his team, we now do the vast majority of the eye cases here in our building in this region. And now when for some reason one of the ophthalmologists has to do a case in Eau Claire, for example, we had a situation a couple of months ago where we had some air handler difficulties and we had to shut down an operating room. When those cases went back to Eau Claire, the ophthalmologist wanted to take their Menominee nurses with them. So I expect that going forward, we will continue to have a robust outpatient surgical practice, and we'll continue to look for opportunities to bring particular specialties and particular procedures here to this site. Frankly, because there's not operating room time in Eau Claire, and there's no other option but to optimize what we have. So we just hired a plastic surgeon who started doing cases here in Menominee not long ago. We've got a vascular surgeon who does vascular cases here in Menominee. We've got our general surgeons who are really busy doing endoscopies, which is greatly needed. We've got orthopedic and podiatrists, and there are likely others that we haven't even considered yet. So let me just bring it home. I don't know if this is familiar to any of you. Don Berwick is a former administrator, former leader for an organization called the Institute for Healthcare Improvement, or IHI. Don conceptualized this triple aim, so bettering population health, decreasing cost, and improving the patient experience. That was really his North Star and his aim for healthcare in the country. Since then, we've added a 4th pillar to that, and that's provider experience, because we know without being able to take care of our staff, there's no way we'll be able to meet any of those other 3 goals. So, look, I want to be honest, there's lots of challenges on the horizon. I don't want to sugarcoat this. I really, truly don't want to be Pollyanna. But I think we here in Menominee are in a tremendous place, thanks to you, thanks to the community for your trust in us, thanks to Mayo Clinic for stable footing and for the organization of a tremendous system of care. And thanks to our staff for being willing and able to be innovative and trial things here at Menominee that nobody's ever done before. I really think after coming home from this conference in Kansas City last week, if anybody can figure this out, we can. I know there's lots of people around the country who are doing really great work. And I truly think healthcare in the future is going to look different than it does today. As healthcare in 2020 looks vastly different than healthcare in 1945. But I think that's okay. And I think we will continue to be here. We will continue to be a strong presence in our community and look forward to providing care for all of you and the rest of the population. So, with that, I will shut up and I will open for questions and conversation. Yes?
I can appreciate Mayo's position, and I'm glad that Mayo is part of this community. I congratulate the outpatient and the ER. I think they've done a tremendous job in there. They really do. Does she need to talk to you?
I just am requesting that after, because you can't be heard by some people, that if Dr. Horvath would repeat what the question is.
Absolutely, of course.
Okay. What I was saying, that I appreciate what you are doing. However, I have a big problem with family medicine treating adults. We need internal medicine. We need adult medicine. Gerontologists would be optimal. That would be great, because there is a big senior community here. And going to family medicine with little giraffes on the wall just doesn't cut it. Having been in healthcare for 40 years, I've seen the changes. Some good and some not so good. But I really think that as adults, we need adult medicine, not family practice. I don't want my doctor to go from treating a baby to treating my needs as an adult. Vastly different, vastly different.
Sure. So let me repeat that so everybody can hear it and everybody can hear it on the camera. And sorry, I didn't mean to step on you.
I wasn't finished. But the other thing is having seniors do this trek to Eau Claire or Rochester. We have a hard enough time with mobility and transportation. And asking people to travel to Eau Claire, especially in the winter, or to Rochester, is kind of unrealistic. People will not get their care. I have a proposal, which you won't like, is transportation. If you want us to travel to these places, provide a medical transport. Ground doesn't have to be flight, which they do a good job at, but ground transportation if you really want us to go there. The other thing, will robotics be offered in Menominee, or will a patient who has robotic surgery have to go to Eau Claire or Rochester?
So there's a few different themes there. Again, let me try to repeat those so everybody can hear. So one was concern about lack of internal medicine in the community. Two is a question about medical transport, or our proposal for medical transport. And three is a question about robotic surgery. So I'm going to try to answer those in series here. So let's touch on internal medicine. And I tried to make a couple of comments here, and again, I would invite others to chime in here as well. Internal medicine is one of those things that that they just don't make anymore. Internists coming out of residency training don't go to a clinic clinic practice as Dr. Johnson did, and Dr. Johnson is a physician that I suspect many of you knew here in the community. Guys like him just don't exist anymore.
You still have internal medicine at the Claremont.
And so we do have internal medicine at Claremont, and that population is aging, and I expect a number of them to be retiring here any minute. So I think your point is well taken.
What about gerontology?
Gerontology would be a wonderful addition to our practice, and there are family medicine gerontologists. Actually, Dr. Murdy was one of those who, Dr. Murdy recently retired. So yeah, I think that's a great comment and certainly a great opportunity for us to recruit going forward if we can find those people, and if we can convince them to move to Menominee. So that's actually going to be one of my calls to action to the community. Is if we want these specialties, we need to roll out the red carpet and really facilitate them coming in and falling in love with the joys that is Menominee.
Well, this older population requires more need medically than a person coming in, a young person. They don't tend to have as many problems. They have sore throats and stuff. But we have need of more intense medicine. In order to meet that, family practice cannot spend the time.
I'll say family medicine is absolutely qualified to provide that care.
They're qualified, but they cannot spend the time. And they do as good a job as they can, but they are overworked.
So let me talk about another what I think is exciting opportunity. We're doing a pilot right now in our Glenwood City clinic. We know that there are no internists in Glenwood City. We know that Glenwood City is frankly in the middle of a medical desert. We know that we are really, if we can't recruit an internist to come to Eau Claire, the likelihood, an internist to come to Menominee, the likelihood that we'll be able to recruit an internist to live in Glenwood City is darn near zero. And we know that internet access in that part of the county is really awful. And we know that drive time is not a possibility for lots of people. So one of the things we're working with is a number of departments, so patients can come into that Glenwood City clinic, basically use that as a technology hub, and connect with their internist or nephrologist or cardiologist remotely, and get the care they need. We're piloting that with 3 departments right now. I'm expecting that pilot to be successful and scale to other departments going forward. Lastly, I just want to talk about the robotic surgery. Robotic surgery is a fascinating topic. I think nobody really knows where robotic surgery is going. Right now, robotic surgery needs a pretty big operating room and lots of technology surrounding the robot. So I'll say right now we don't have that capability in Menominee. Our ORs just aren't physically big enough to meet that need.
Do you see the hospital growing in structure?
But could there be an opportunity in the future where robotics is done remotely? Gosh, I think that would potentially be really cool. I can't tell you where that's going to go. Your question about the Menominee Hospital physically growing, yeah, I think it will. Yeah, we have plans to kind of revamp the ORs as capital is available. But again, as we talked about earlier, if expenses are going up 10% and revenues are going up 5%, capital is going to be hard to come by.
Well, seniors have a difficult time as it is financially these days.
So do hospitals, absolutely. Yeah, a lot of people do. You bet.
They do.
Yes, ma'am.
The slide about doctors' FaceTime and electronic time horrified me. So what do you do about, I know myself how
Yeah.
much time it takes to do something on the computer when I could have written that longhand much faster. But anyway, what are you doing about that
Yeah.
and why? What do they have to do electronically?
Yeah, so a couple of thoughts. Again, just coming from this artificial intelligence conference, we're at a point where we have a tremendous data set of patients throughout the Mayo Clinic enterprise. And now we've got the computer technology really to start to churn through that and really help us personalize care and focus care. So that's the why. How do we fix the input going forward? That's the how. There's a handful of pilots that are going on. Couple of things come to mind. One is really in the last couple of years in my practice, there's a concern called note bloat. So basically, we're documenting things in the record that probably don't need to be documented or frankly documented somewhere else. So how do we streamline our notes to not have all of that bloat? Secondly, again, there's some pretty cool technologies. Megan, you may, sorry, I keep calling on you. You may know more about this than I do. But there's some cool technologies where there's basically a microphone in the exam room capturing a lot of that data and transcribing it real time into a note. So therefore, I as a physician have less work to do on the back end to actually enter some of that data.
I think that's great, but you also see what's going to happen with autocorrect.
Yes. We've tried, actually in my practice, we piloted Scribes a number of years ago, which was a kind of pro-con. The biggest downside that many of my colleagues had was that they had to go spend as much time going back and re-editing the note afterwards as they would have just entered it in the first place. Yes, sir.
Given all the pressures on the medical system that you've mentioned and the growing number of senior citizens, some seem to be living longer and others seem to be dying longer.
Good. That's a good distinction.
Can you speculate on the future of end-of-life options?
Yeah, that is.
Repeat the question.
Sorry, thank you. So I was asked to just speculate on the future of end-of-life options. That's a really interesting discussion. We've been doing some work with my colleagues looking at patients who are readmitted to the hospital within a short time after their discharge. And a number of those readmissions were simply due to incomplete end-of-life conversations. Many of those conversations do not need to be held by a physician. The physician absolutely needs to be involved, but what I can tell you, one of the things we're doing is working with social workers and nurses who frankly are probably better skilled in those conversations than we are as a physician, or at least I am as a physician, in guiding patients through some of those discussions. The La Crosse area has really been a nationwide leader in getting what we call advanced directives on patients' charts. So I'm hopeful. I know there's active work going on in our region to learn some of those lessons and apply some of those lessons, and frankly, we need to. I think there's no question that those conversations need to be had and documented.
But in addition to advanced directives and things like that, what about medical aid in dying?
Yeah, I don't know that I can address. So the question was, well, what about medical aid in dying? I don't know that I'm equipped to address that question specifically. I can tell you there are some. I didn't get into this in my presentation, but there's a movement in healthcare. The American Board of Internal Medicine was really a pioneer here in trying to limit non-beneficial care. There's a movement called Choosing Wisely. And essentially the concept is each specialty is encouraged to identify care that we all do for various reasons that may not be beneficial ultimately to patients. And equipping patients to be able to have those conversations with their care teams. We know that there's a lot of non-beneficial care, particularly as we get into an end of life. And I'm hopeful that as we move truly to a value-based rather than a volume-based care incentive model, and start to have these conversations with patients and families, we'll make progress there. Megan, you comment?
Do you want me to answer the medical aid impact?
Please, go right ahead.
Hi, I'm Dr. Megan Baird. I'm a family doc here in town, and his wife. And I'm also the ethics chair for Northwest Wisconsin Mayo. So I have a lot of experience in conversations about end of life. To your point about medical aid in dying, Wisconsin is not, at this point in time, considering any type of medical aid in dying legislation that I'm aware of. Minnesota is. Mayo Clinic, at this point, the ethical community does not support that bill. Medical aid in dying is very tricky, right? Because there's a lot of ethical considerations with patient autonomy, because we want patients to be able to make the decisions for how their life ends. But we also, as a medical community, don't want to be going against our oath as physicians and hastening death. So my personal recommendation is that we, and I think we're working on this, need to invest a lot of more time and money into making a more robust palliative care practice and a more robust hospice care practice, so that patients that want to die at home have the support that they can stay comfortable and reach their end naturally without us hastening it through a medical aid in dying process.
Yeah, thank you. I'll just add one additional comment, and this does come back to kind of state law, and that's around guardianships and medical decision makers. So particularly as folks age and for one reason or another lose the capacity to make medical decisions for themselves, Wisconsin needs, and Megan, correct me if I misstate this, I know this is a passionate area of yours as well. Wisconsin requires that there is a named alternate decision maker. It's not just assumed that if I pass away, Megan makes those decisions and vice versa. So what we are seeing is patients come into the hospital with a critical illness, do not have that guardian or power of attorney named, and then either stay in the hospital for a prolonged length of time waiting for the courts to work through their process, or get named a corporate guardian whose likelihood of proceeding with what many of us think would be appropriate end-of-life care is close to nil. So I know there's legislation working its way through the state in that regard. But this is just a plug. Get your power of attorney done and signed.
Yeah, there's actually a law in Wisconsin that many corporate guardians feel obligated to pursue maximum cares. So if you have a wish that you would want less aggressive cares as you're dying, you don't want to end up with a corporate guardian. You want to have named someone that you trust, and whether that person is a family member or a close friend, you want someone who you know is going to instruct the physicians and care team as you would wish. I know I've seen a lot of situations where a spouse maybe isn't the best person to make decisions because they don't want to let you go. And they're going to make those decisions very emotionally. You want someone who's going to be able to step into your shoes and help make those decisions. Mayo Clinic has very wonderful social workers that can walk you through the packets if your physician doesn't have time. I do a lot of talking about power of attorney for healthcare in my office because it is a passion of mine, as Paul mentioned. So it's definitely something that I talk to my patients about, but I know that a lot of my colleagues don't maybe have the comfort level to say, hey, you need to think about what the next steps are. And that includes some of my specialty colleagues. I pick on the oncologists a lot because they worry about taking away hope. They don't want to say, hey, you're going to die. But you know what? We all do. Nobody gets out of it alive. Death and taxes, right? So it's important to be thinking about what your wishes are. It's important to be sharing that with your family. We're getting close to the holidays, folks. There's a great program called Death Over Dinner that you can look up online. It's just deathoverdinner.com. And you can have these prompts for essential conversations about this type of stuff with your family over the holidays. So it doesn't sound like it would be fun, but it's actually kind of a really interesting conversation once you can get past some of those ick factor barriers that sometimes the family will have.
Thank you. If I may, just one moment, I wanted to come back to the lady in the corner's question about internal medicine and geriatric care for just a moment. Again, point incredibly well taken. Physician workforce is a tremendous barrier to just simply meeting what you're asking for. Two additional comments that I thought of as Dr. Beard was talking. Number one, healthcare is a team sport. So we all work with non-physician colleagues who can provide much of the care as we direct, and who do provide much of the care as we direct. And we know that's just as true in geriatrics as it is in pediatrics. The resources we reach out to may be different. The other comment is we know much of that care can be completed outside of an office visit. So the questions are how do we do that, and those are questions that we'll need to continue to explore. Question down here in the front, sorry.
I know it was this way that I'm going to say. I'm not certain it is now because it's been a while since I had that contact. But I believe people can call your social worker and she will schedule you an appointment and go through the packet that you had discussed, which you would entail a discussion with the social worker about what your thoughts are. And these forms are filled out that you can take to your family and ask whomever to be a representative for you. And then that goes into your electronic chart so that if there's an accident or something, the facility here has the information of what your wishes are and who your contact is. And that's provided by Mayo, no charge. Is that still the avenue?
Absolutely. So just to reiterate, yes, we do have at least one social worker, if not more, who does outpatient visits, so office visits, who can work through a conversation about advanced directives and end-of-life wishes and appropriately document all of that stuff. That then gets scanned into the EMR. So when somebody comes into the ER, I can find that document pretty quickly and start to understand what those wishes are. So yeah, absolutely, well said. Thank you.
And the electronic chart can be updated to reflect those things as well.
Perfect. Yes, thank you.
What? Repeat.
And the electronic chart can be updated to reflect those things as well. So thank you. There's a question back.
Yeah, hi. I just wondered if you can talk a little bit about competition between healthcare organizations for healthcare dollars and how that affects healthcare and the cost of healthcare, and also just fold that maybe into how it affects home healthcare. I know that home healthcare seems to be not as available as it used to be because healthcare facilities or organizations are retaining those patients, but home care is really inexpensive and a really nice way for patients to receive health care.
Yeah, absolutely. So two questions. One was about competition for healthcare services, and the other is about home care services. And again, I'll try to address those. In many rural communities, and I'm going to focus on rural communities, there often tends to be a healthcare provider of choice. We're fortunate in Menominee to have 3 healthcare organizations within the city Mayo Clinic, Marshfield, and Prevea. I really hoped that those other two representatives would be here today to kind of join in some comments. What again I think we're seeing is particularly smaller healthcare organizations merge with others. So functionally, I think that ends up, that competition piece ends up not being as big a deal as it might in other industries. As far as home care goes, because I think that's actually a really interesting topic, and I didn't get into it. As we talk about the topic of consumerism and personal care that I mentioned earlier, home care is a big part of that. There are some pretty detailed rules and regulations about home care as an entity. And again, staffing being what it is, I can tell you we at Mayo Clinic have had to kind of contract our circle of people who are eligible to receive home care just because we don't have the people to drive out and do the work. Going forward, I think home care is critical, and home care has got to be a key piece of value-based care, cost containment, and personalized care. So on the outpatient side, I think patients are going to receive care in their home and are receiving care in their home through various mechanisms, including virtual visits. I know in other parts of our health system, we use community paramedics as extenders to reach out and provide some of those services. And actually, I'm working on a project right now trying to figure out how to get lab tests drawn for patients in their home without them having to come into a facility.
Do you have a visiting nurses association group?
I am not aware of one. If anybody else is, please speak up. Yeah, I was just going to get there. So that's the outpatient practice. As we get to the hospital practice, home calls are coming back. So one of my colleagues is leading a project called Advanced Care at Home. Excuse me, I just hit a button and we'll shut that. Called Advanced Care at Home. Advanced Care at Home is essentially hospital level care in the home. So what we're able to do is work with a team of healthcare providers, a hospitalist, a hospital internist, plus a PA, generally it's a PA or a nurse practitioner, plus nurses, plus community paramedics, plus pharmacists to do all of the stuff that would be done in the hospital, IVs, monitoring, oxygen, rehab, et cetera, in the patient's home. And right now, just with current funding mechanisms in our practice, that is really only open to patients within 30 miles of Eau Claire and who would have been admitted to the Eau Claire hospital. And again, that's purely based on funding. I know there's work being done to expand that into the critical access hospitals as we speak, and I'm hopeful going forward that many of you here in Dunn County will have more access to advanced care at home in the future. Yes, ma'am.
It's an old concept, the visiting at home, and I was a visiting nurse in the Orlando region in Florida, and I went out to orange groves, I went to laundromats, my car was my office, and I'd go into some really rural areas.
Yep.
And people that weren't able to leave their home. And we did infusions, we did blood draws, we did a number of things. And I think that would be a wonderful thing to bring to this community, being in a rural community.
Yep.
And the things that the nurses see out in the field explains to the doctors at the facility what is going on that they wouldn't normally see, because you can find out a lot of things in a person's home about them and their lifestyle and what's going on.
Yeah, couldn't agree more. So the comment was about visiting nurses, and and the value of visiting nurses. And I'll just add to that. We received a $9 million grant from the state to work with UW Eau Claire to build a curriculum for what we call community health coaches. So a lot of those same roles not performed by a nurse, but performed by another healthcare team member. And we're training the first class of those folks right now and look forward to getting them out into the community. I know in particularly, we're working with the Glenwood City, the Glenwood Library, to have one of the community health coaches posted there periodically to help facilitate some of that outpatient need. Yes, ma'am.
I'd like to say that we have a problem here in Dunn County because the Dunn County wanted to provide home health care, but because of the expense of it and the limitations on budget, they had to discontinue it. So that's one reason why we don't have the health care that we used to have, which was excellent. And it was a real disappointment to the people working at the county that they had to let that program go.
That is unfortunate.
Yeah, and that's, again, that's a highlight.
For a long time.
Oh, I'm so sorry. That again highlights the challenge of public health infrastructure and government infrastructure, and highlights how hospitals and healthcare, private healthcare organizations are making some inroads, but again, just aren't able to meet all of those needs. And I'm sorry, ma'am.
No, that's fine. I just wanted to make a comment about, you indicated that there's a huge doctor shortage and it's just going to grow, but that it's actually Congress that makes those decisions about how many places there are. Is that because of subsidies in medical school? That the government has to pay a certain amount of money, and so that fear of expanded budgets for medical care is there?
That's exactly right. So the government funds. I'm sorry again. I apologize. So the question is really about funding mechanisms for medical education and why that physician gap exists that I highlighted earlier. So yes, to your point, the federal government does subsidize medical schools. There are some work being done to grow medical school classes currently. But again, the government is the primary funder for residency training. And residency spots have not grown since 1997. So we can create all the medical students we want, but if we don't have the residency slots to get them through, there's still a bottleneck in that system.
We're already creating more students, more doctors than there are training
Programs.
And is that
Yeah.
because of the hospitals?
locations for training.
Well, no, just
I
that
gotcha.
I'm sorry, I'm blanking, but with all of the mergers and the closings of different hospitals and things like that, there's not slots?
No,
Or there's
it really comes down to, there is a number of slots that are paid for by Medicare, and they're not making new ones.
But again, it comes down to money. It's not
It's
the
always that
facilities, or it's not
Correct.
facilities being willing to take more residents.
Yeah, there are a few pockets. Again, I think Kaiser comes to mind. I forget exactly what system, but they're trialing some private ways to fund those. But I'll be the first to admit that I'm not a finance guy, but the finances are a real struggle if you try to fund those through private mechanisms.
And I just have a follow-up question in relationship to home care.
Yeah.
Is there will be laws passed where family members can take care of people and get paid for doing that. And then there'll be people who will lobby the different states or the federal government to take that away because private industry wants those jobs, which they cannot fill and they do not keep because they're low paid for the most part. And so where does the medical community stand in terms of their lobbying ability to not just have it be about profit or who speaks the loudest, but actually about outcomes?
Yeah, great question, and I think this is one of the key tension points right now.
Repeat the question.
So the question was about lobbying for home health and layperson home care dollars. I think you ask a brilliant question. I don't have a perfect answer for you, but I know organizations such as the Hospital Association and the National Rural Health Association, both of whom I just interacted with, have home care and skilled nursing care as high priorities on their advocacy lists. Frankly, I think we need to create more incentives and more skills around providing lay people the knowledge and skills to be able to care for their loved ones at home. I can't disagree with you at all.
But if they're paid by the local government, you have to pay back the money that they paid.
So there's a question in front here.
That's not very good.
Earlier in your presentation, you showed us that government is a major player in financing all healthcare in all of that. And you also showed us that the place where healthcare costs are rising very rapidly is in insurance. Well, it seems to me, and then I hear about Medicare Advantage plans, which are raped of money by the bureaucrats on Wall Street. I know it's political,
Yeah.
but it's not partisan, and we're a political organization that is not partisan. We need to somehow address these problems.
Amen. Yes, sir.
Paul, is actually closer to 2/3 of funding for healthcare in our country comes from governmental
Okay.
agencies. Because what you had on your slide was federal funding.
Ah,
But we also have state
Medicaid,
and
thank
local
you.
funding, and those get shuttled through private insurance. So I'm on the city board of La Crosse, and we're doing our budget right now, and we're very aware of how much it costs to provide benefits, ordinary benefits, to the employees of La Crosse community government. That is public funds that's going through private entities, and they're taking off their 15 or 20% before it gets back to the people we have to care for, who are agents in our city government.
Yeah, absolutely. So private healthcare, I'll just make one comment. There's a reason why if you drive through any major city in the US, it's the insurance company that has the biggest building. Yes, ma'am, in back.
So I'm going to go back to home care. So I used to work for Dunn County Home Health as a staff nurse. It's been about 15 years now. And one of the things that was happening when I was there is our census was dropping because Community Health Partnership came in. That was brought in. I think that was a state mandated thing. And they started doling out the patients, and we would get the patients who had the most problems, and we could not make money. Because Medicare only pays so much, there's your first payment, and then there's your second payment, it just keeps going down, and they want you to get that patient off your rosters. So we watched that happen with the Health Partnership, which changed names many times. But also we saw Mayo, not just Mayo, but probably Marshfield as well, Sacred Heart, everybody keeping their patients, keeping them there and not sending them home for their wound care, for their follow-up care with nurses. But it's an amazing thing, to have that face-to-face, and like you were saying, you see stuff and you would communicate that to the doctors. You don't understand.
Right.
They're a hoarder. They've got this going on. They got 25 cats living in their house. They've got this going on. They can't see that. They're not going to be able to take their blood pressure every day. They're not going to be able to weigh themselves for that blood pressure patient. All of that. So if there's a way to get back to that, and Medicare, it used to be that was like your, a healthcare benefit was home care. And I don't even know if it is anymore, if it's just not accessible, because I used to tell people, you can call and get a referral to home care and have this done at home.
Yeah.
And then they don't have to travel somewhere.
Yeah,
It's super helpful for families too. It's super cheap.
Again, amen. I couldn't agree more
So I
with
just
that.
wanted to bring that up, yeah.
So the comment was about home care and again, the benefits and challenges that have been experienced at the county level with home care. I wish my colleague, Dr. Paulson, was here. She has lots of horror stories about patients that are enrolled in the Advanced Care at Home program, and the amazing things that get learned when you're actually able to interact with a patient in their home environment. And what a better way, so the term within the medical community is social determinants of health. What a better way to understand those social determinants and drive outcomes.
What was the crossover with the nurses and social work? You were actually doing social work, but doing nursing.
Yes.
Yeah,
Yeah,
yeah.
really great
It was very
relationships
valuable.
with family members and.
Very
and members
valuable.
from the community.
We've got a few minutes left. I see a hand in the back.
So I just wanted to challenge one of the things, and I can't remember during your presentation,
Yeah.
you said something about the healthcare costs in Wisconsin are second or fourth lowest in the nation. That does not absolutely translate to anywhere in the Chippewa Valley area. If you go on something called the Healthcare Blue Book, which my previous insurance company encouraged us to use, as a matter of fact, they encouraged us to use it to the point where if we would drive 75 miles to 100 miles away from the Chippewa Valley area, they would pay us $200 to $800 depending on the procedure, because the cost here in the Chippewa Valley area is astronomical compared to anywhere outside of this area. For example, it's just my own personal experience, that the fair market value for colonoscopy, Medicare and Medicaid will pay approximately $1,200. The Red Cedar Clinic quoted me at over $7,000 for that same procedure here, where I could have drove 100 miles away and got it 7 times less than that amount.
So that,
you know, I mean, I hear everybody asking for this service and that service, and for me, what I hear is you're just raising the cost more of something. None of the options that you're suggesting are doing any good to anybody if they can't afford to access them.
I will give that an amen. So the comment was about costs of care being high in the Chippewa Valley. And I've got a few comments. I think you're probably not wrong. There was a study by the RAND Corporation. The RAND Corporation is a think tank, I think based in Washington. They published a study 4 or 5 years ago, maybe, I forget the exact date, and listed out the costs for various services for all sorts of organizations nationwide, and essentially allowed you to kind of look. This is what organization A charges. This is what organization B charges a block down the street, and frankly, the variability there is tremendous. I also want to comment that there's a difference between cost and charges. And I will be among the first to note that charges at Mayo are too high. That being said, we are working very hard to contain our costs, so we can keep charges low. Other questions? Yes, ma'am.
Years ago, we had a doctor in a rural area. He was a young doctor, and he was there because by working in a rural area, he got his full costs forgiven. And as far as I know, we don't live there anymore. I think he retired from that area. So he, moved there. And so where you were saying that recruiting a doctor that we want in this area, is that kind of program still available?
It is, and I know colleagues of mine have participated in those kind of programs. There's also programs on the federal level with various visas. Those programs, and again, others in the room may have more knowledge than I do about the specifics. Those programs are very tightly regulated, and an area has to be designated as a medical service high need area. And I'll be honest, I don't know all the specifics that go into that designation. I believe areas like our practice in Osseo is one of those. I can't speak to Dunn County off the top of my head. The experience we've had with the visa programs is many of those physicians do not finish out their career at that site for various reasons. I know we here in Dunn County have had conversations around housing. I know I've talked with Chancellor Frank from the university. I know I've talked with folks from the chamber. But I do think we've got opportunities as a community to make this a more desirable place to recruit. Megan and our family and I have lived here for 15 years now. Feel like we're a part of the community, and I frankly couldn't imagine a better place to live. Somehow we need to be able to communicate that better to the professionals that, including physicians, but other industries as well, that are potentially looking to come here. We've got, I think, 4 minutes left, 3 minutes left. Yes, sir.
I just wanted to comment, I think he brought up a really good point about medical costs behind Chippewa Valley. I was working full-time for the Salvation Army back in 2004 in Eau Claire. I had to have my gallbladder out. It was about $12,000. My insurance provider through Salvation Army, I got a statement from them saying the costs you incurred for your surgery were above ordinary and reasonable, and they only covered 50% of my surgical costs. Thankfully, I had a supplemental insurance policy which picked up the difference. Had I not had that, I would have been stuck paying payments on a $6,000 bill, which I found really infuriating because of the fact I don't have any control over what they charge. And, I think sometimes, if you look at different areas, there's going to be different costs. The other thing that I've noticed in this area, especially with Mayo, because I do go to Mayo and Eau Claire, the charge for consultation visits, lab visits, they're just off the roof. I mean, it's nothing to spend $200, $300 just to get a blood draw, and I can go to Eau Claire County if it's something simple and get it for a fraction of that. And I'm thinking, at some point, where do we get these costs more in line? I realize Mayo has overhead costs. They're an excellent clinic. I really like Mayo, but at the same time, I'm finding a deterrent to use some of their basic services just because of the increased costs. So I don't know, what's your thought on that?
Yeah, I've got a few thoughts. Again, I think we all recognize that our charges are higher than others in the area. We think there's additional value that we bring, but we recognize that our charges are higher. Again, looking back at our recent budget discussions, costs are up. Our costs are up 10%. Our predicted revenues are up 5%. Where does that work out? Well, you either raise charges or you cut more services. Pick a bad option. I guess the other comment is this is a common, I'll use the term game, but common strategy played by our private insurances in refusing to pay charges. That frankly, that's how they make their 20% income and how they pay their executives and build their buildings. Yes, sir.
I want to point out one more thing. I saw on the news that, talking politics, the president today, that is our president, put forth the name of a head of a Medicare Advantage insurance company to go on the board of Medicare to oversee it. So our problem is widespread. Money controls this nation, and our problem is Citizens United and what the Supreme Court has done to us. And we ought, as a nation, to address that, especially when we see the corruption in the judges that did it. Thank you.
You all need to vote.
Everybody, I think we're going to get the hook here. I feel like I'm going to get the hook here in a minute. Thank you so much for your time. Appreciate it.
I'd just like to say there's a few handouts in back, and then someone has a petition that if you wanted to look at that and see if you wanted to sign it, that's okay. But this is not political here. You can be of any kind of party, that's fine. But it's just that one of our members wants you to see that petition and see if you go ahead and sign it.
Petition for what?
It's on the Supreme Court judges for the state. So, but there's also some handouts back there, from the Mayo Clinic if you wanted to pick those up.
Yeah, I'll just add, one of my ulterior motives today is to try to recruit some volunteers. If anybody wants to volunteer in what's really a dynamic place, a really, really wonderful place to work, despite challenges that we talked about today, please pick up a brochure.